Next is Thomas MacLaine. Frailty, the fragile indicator of surgical outcomes.
Frailty. Frailty has been described in the Lancet as the most problematic aspect of population aging. And as you'll all have heard in the media, we have an aging population. Frailty, instead of being the chronological aging that we all know and celebrate, is the biological aging of a patient. And frailty is defined by an inability to return to baseline following a stressor. My PhD is interested in the stressor of surgery. Frailty is a monumental aspect that we all need to consider. If we take, for example, Falja Singh. Falja Singh, on the top right-hand side of the screen, retired from marathons at the young age of 104. I get out of breath saying the word marathon. My patients aged between 65 and 90 who are coming for surgery can sometimes struggle to climb a flight of stairs. Falja in the blue and a frail person in the right undergoing surgery on this graph. A frail person already starts off at a lower baseline. During the surgical insult, the impact is greater and the patient has a more reliant care need. Post-operatively, it takes them longer to progress, to recover, and they establish a new hindered baseline, meaning that these patients are more likely to undergo post-operative complications, morbidity, mortality, and require additional support care such as nursing homes. Frailty is not identified routinely in hospitals. My PhD has identified that 32% of our surgical patients are frail. 66% of our patients are pre-frail, an intermediate stage, meaning that they're likely to become frail as a result of their surgery designed to improve their health. And this is a really big impact. So for colorectal cancer patients, they have a 6-week window of opportunity preoperatively. And what I've done is I've designed an intervention for frailty. Using 4 weeks of exercise training for 15 minutes a session, we can support our preoperative patients to increase muscle strength by up to 40%, which then can take that strength through to their recovery. Using quality improvement methodologies, I have also implemented frailty into routine care, using a collaborative that I've developed with colorectal surgeons, care of the elderly, anaesthetists, but also physiotherapists, nursing staff, and the pharmacists, so that we can sustainably identify patients coming into surgery, proactively tailor their care needs, and ensure that they have the social care, the medical care, and their loved ones there for the patients in their greatest time of needs, where we're supporting them the most. Thank you for your time.
Thank you, Thomas.